All right, next up, we have Dr. Andrew Bernard. He's professor of surgery and chief of trauma at University of Kentucky. He's going to talk to us about enhanced plasma availability.
Well, good morning again. Some of the speakers from yesterday set me up nicely today for some discussion of some of these concepts, so it's a great lead-in. You'll see some reiteration of some of the concepts that were talked about yesterday. So this is what I want you to leave here with. I want you to be able to list the major benefits of early plasma and then outline some of the major barriers. So a bunch of trauma coordinators in here, a bunch of ED nurses, ICU nurses. How many people are convinced that they have the perfect massive transfusion protocol and they have no problems with it at all? That's great. Okay, good. I'm among like-minded individuals. These things aren't perfect. We just keep working at them to make them better. And lastly, we'll describe system interventions that are relevant to your team to make plasma available. I don't have any conflicts to disclose. So this is basically what we'll talk about. Why plasma? Why plasma early? You heard a little bit about that yesterday from Dr. Eastridge. Different plasma types. It's not all just FFP. Optimizing plasma delivery, which is the key. You got to get it to the patient in a timely way. I'll speak a little bit. I'll touch on some options for plasma shortage, and then I'll give you some future. So this is a good answer to the question of why plasma. Remember, we used to think that coagulopathy from injury came from getting a lot of IV fluid, and it dilated down all your clotting factors. And that's partly true. You know, we don't give crystalloid like we used to. And we used to think it was because we gave cold stuff, and that made you hypothermic, and we know hypothermia exacerbates coagulopathy, and that's true. But there's this newly discovered concept that very early after injury, really before you've had very much resuscitation at all, you can be coagulopathic. And it's the result of an inflammatory cascade that occurs at the moment of injury. The more severe your injury, the more likely you are to have this coagulopathy that comes just from the impact of the injury. We call this the acute coagulopathy of trauma, and it's highly deadly. On this figure, you see a bunch of authors on the far left column, and then you see how these authors defined coagulopathy of trauma. It's usually a PT or PTT elevation, and you see the number of patients in their study, and then you see the percentage of patients that presented coagulopathic. So this is early coagulopathy shortly after arriving in the trauma room with very little resuscitation. Up to a third of your patients may have coagulopathy as they're hitting the stretcher in the minutes thereafter, even very early after injury. So it's pretty prevalent that patients come coagulopathic at the beginning. And if you look at the mortality from this, those patients are much more likely to die. So in this bottom box, you see the mortality of a group of patients whose coagulation is normal, and you see the mortality of the patients whose coagulation is abnormal. So it's fairly common, and if you have it, you're much more likely to die. That makes the correction of this coagulopathy imperative. This is probably the first glimpse of the relevance of early high-ratio plasma resuscitation, getting plasma in early. This paper was published in 2007, so this is during Operation Iraqi Freedom, and this is a series of soldiers. So these are young, physically fit, wounded soldiers, and they're in three groups here. The group on the far left is the group that got 1 plasma for every 8 reds. The second group is 1 plasma for every 2.5 reds, and the group on the right is 1 plasma for every 1.5 reds. And mortality is on the y-axis. So what this suggested was that the soldiers who got more plasma per red given were less likely to die. Dr. Eastridge touched on this yesterday, and he said, people criticize these data initially, some people still do, and they say this is the result of survival bias. They didn't survive because they got plasma. They got plasma because they survived. That's the argument of survival bias, right? They lived long enough for us to catch up and give them plasma, but they were going to live anyway. It wasn't the plasma that saved them. That's the argument, right? We've since put that that survival bias issue pretty well to bed, I think. And this is one of the important studies that helps do that. So this is 2013. This is 6 years later. Same author, John Holcomb, who's the lead surgeon for the Army, and now he's in Houston. He's the medical director for Prytime, who makes the Reboa catheter. The prospective observational multi-center major trauma transfusion or PROMPT study. This study was intended to address that issue of did they survive because of the plasma, or did they get the plasma because they survived? There are two groups of patients here, or two aspects of this that they looked at. The two rows here is high ratio plasma to reds and high ratio platelets to reds. Those are the two rows here. And they looked specifically at time intervals. And this interval that's shown here is the 31 minutes to 6 hour interval. So did you reach this high ratio early? And if you did, what was the impact on mortality? And then you see three columns off to the right. Low ratio, so less than one plasma or platelet for every two reds, and then 1 to 2 to 1 to 1, or greater than 1 to 1. You got more plasmas than reds or more platelets than reds. That's unusual. The hazard ratio is the reduction in mortality. So what you see in the moderate group, the group that got 1 to 2 to 1 to 1, somewhere better than 1 to 2, at least one plasma for every two reds or more, their hazard ratio for mortality was 0.42. So they're about half as likely to die. And if you push that more than 1 to 1, maybe they were a quarter likely to die. This seemed to also be true for platelets if you hit that 1 to 1 or better ratio. So this paper puts some of that survival bias argument together. High ratio plasma, high ratio platelets definitely makes a difference in mortality, but you got to get that ratio early. You can't just catch up over 24 hours because they're dead by then, right? If you're talking about hemorrhage control, remember, as I teach my residents, if somebody arrives in the trauma room alive and is dead in an hour, how'd they die? I say that to my residents all the time, and I want to hear bleeding. I say, right, bleeding is enemy number one in the trauma room. So you got to reach these ratios early, you can't delay. So that means your system for plasma delivery, your massive transfusion protocol has to work well, even though it's a constant struggle for all of us. So what are the plasma types? Well, there's fresh whole blood. Dr. Eastridge touched on this yesterday. Very powerful, available in the military, theoretically available in the civilian setting, but really quite complicated because of the issue of risk, right? There's a certain amount of testing that's required. So fresh whole blood is tough. Stored whole blood, I edited my slides overnight because this used to say coming, and now it's today, and you heard about that yesterday. It's today, stored whole blood. Fresh frozen plasma. So fresh frozen plasma and FP24, frozen plasma within 24 hours. Fresh frozen is frozen right away. FP24 is frozen within 24 hours. They're essentially the same in terms of their clotting factors. The key for you in a trauma center that sees a fair bit of volume that needs to have plasma ready is that it just can't be frozen when the patient comes because the thawing is a challenge and takes time. So you have to have it ready, which means if you've frozen it and kept it in the freezer, that you thaw some of it on a regular basis and have it available, thawed plasma. But once you've frozen it and then thawed it, it has a shelf life of about 5 days. So it's limited once you thaw it. You just need to take it out of the freezer and thaw it at a rate that's commensurate with your anticipated rate of delivery. And that's a blood banking issue. And then there's liquid plasma. It's never frozen. And it has a durability that's much longer, in the range of weeks. So this is probably the ideal. We haven't done this before at our place, but we're going toward liquid plasma. And there are lots of places that do this, and I suspect there's several in the room who are using liquid plasma now. Probably overall easier to deal with than thawed plasma, because once you thaw, you have that short time. And then there's dried plasma, lyophilized plasma. This is available in Europe. We don't have it in the United States, but I heard last night from Chris, who spoke yesterday, who's up in Oregon, who says they're about to start trialing it in Oregon. You're going to see this. It's just not approved by the FDA for utilization in the United States. It's like any other powdered drug you'd reconstitute and give. It sounds really attractive. That's what you see in this picture here. You see some lyophilized plasma. This is a paper written by one of Marty Schreiber's colleagues or residents. If you're interested in this topic of plasma, this is a great review. Schreiber 2016 plasma. You probably get about 20 articles from him, but this is the one that you'd want if you wanted to read about this. He talks about all the plasma types. So how do you optimize plasma delivery? Well, you have to create an MTP that works. So what should your MTP look like today in late 2018? You should pack it right, and that means 1 to 1 to 1. 1 to 1 to 1 as early as possible. So that's plasma, platelets, and reds. And then you activate for the right reasons. You need some system for activation, probably more than just Gestalt. If it's just Gestalt, you're going to end up with delays. So have some system for doing it. We used to have a very ornate protocol for this. There were a million criteria, and it was just too complicated. And we simplified it down to the ABC score. One of the speakers yesterday talked about the ABC score, the assessment of blood consumption. This was developed by Brian Cotton when he was at Vanderbilt. Some people say ABC should stand for the Angry Brian Cotton score. If any of you know Brian, he's a little edgy, he's fun to follow on Twitter, but he's forgotten more about coagulation and massive transfusion than I'll ever know. But it is very simple. As was discussed yesterday, there's 4 criteria: penetrating truncal injury, positive fast, hypotension, tachycardia. Very simple. If you have 2 of those, activate, and you're almost always going to capture the patient. You're rarely going to have a miss if you use the ABC score. So that's what we use now. It's very simple. And then you got to activate it early. You got to activate it as soon as those criteria are evident, and that can be when they call in and they say, we're on our way and here's the situation. We got a guy who's hypotensive tachycardic, activate. That's when you activate it. Or penetrating truncal trauma tachycardic, activate. Get the stuff there. It's like activating your trauma team. You want some degree of over-triage. You'd rather over-triage. You'd rather have it there and not need it than need it and not have it. So this was a poster that Brian put on the refrigerator that housed the red cells in the ED at Vanderbilt. Because there were cases where people would say, get me one of those reds out of that fridge, this patient's bleeding really badly. Remember, if you're reaching for blood from your ED fridge or you're calling for uncrossed blood, you're saying, this patient's bleeding so severely that I can't wait 15 minutes to get type-specific blood, and I'm accepting the risk of a major hemolytic transfusion reaction, albeit unlikely. I'm accepting the risk of a major hemolytic transfusion reaction because I think this patient's bleeding so badly. That's a scenario if you're reaching for uncrossed matched blood. So the argument would be, if it's really that dire a situation, then you should probably be activating your MTP. And that's the initiative that Dr. Cotton pushed at Vanderbilt when he was there, and he did that with this poster. Because he worked on a number of initiatives to make the MTP work better at his place, and this is a great paper on how to PI your MTP process. You notice he was able to make all these initiatives, see how they all improved over the quarter. Performance and all these PI initiatives got better and better and better, except for that one low outlier, which was activating the massive transfusion protocol in the ED and not waiting till you got to angio or you got to the operating room. They really pushed hard on this. And then he looked at which one of those initiatives really made a difference. And look at these top 3. If you activate the massive transfusion protocol in the ED, your patient is much more likely to survive. If your plasma to RBC ratio is at least 2 to 3, you're more likely to survive. And if your platelet ratio is at least 1 to 5, you're more likely to survive. This is before PROMPT and all the data that's come since. This was the early prediction that this high ratio resuscitation was the real deal. But most importantly, he showed that you got to activate it in the ED. And he and his group have since published additional data that show that every single minute counts. Every single minute between the time the patient arrives and the time the MTP cooler arrives, or however your MTP comes, makes a difference in mortality. And that's the relative risk you see on the top of that table. Time to receipt of first cooler in minutes. For every minute, you increase the risk of mortality 1.05 times. So 10, 15-minute delay, that can be a significant increase in mortality. So that's step 1. Pack your cooler right, or set up your MTP right and activate it for the right reason. So the next step is make your pool adequately large. You don't want to have a ton available because you don't want to waste, and this is what you work with your blood bank to determine is what the right amount of plasma for you is. But you do need some plasma that's available, and it needs to be thawed so you don't have to thaw it at the time. So the thawed plasma is good for 5 days, as I talked about, and the liquid plasma, LP, never frozen, is good for 28 days. The other option that more and more people are using today is to use type A plasma. This has become pretty popular. We used to use AB plasma as the universal donor, right? We use O reds because no matter what blood type the patient has, they're not going to attack O reds because there's no A antigen, no B antigen on the surface. But the universal donor plasma is AB, right? Because an AB patient isn't going to have anti-A antibodies, else they would be attacking their own red cells, and they're not going to have anti-B. So that's the universal donor plasma right there is AB. But the percentage of patients in the United States that have AB blood type is just 4 or 5%. So it's very rare. So it's hard to get this stuff. That's one thing. And if you take the ABs, which are about 4 or 5%, and the Bs, which is about 10%, only 15% of the population has a B antigen on their red cells. So if you were a betting person and you were short on plasma, you could use A plasma because an A patient is not going to have any anti-B, any anti-A antibody. They would only potentially make anti-B, which is only going to target 15% of the population. So somewhere along the way, somebody decided, well, let's try A plasma because they're not going to make antibodies against O patients, I know that, and they're not going to make antibodies against A. They would only attack A, B, and B blood type. And A is fairly prevalent, so people started doing this, and they started doing it without a lot of evidence. And a couple of years ago, a group of us put together a study to look at whether this is really safe. Now, there was truly a military precedent for this already. There were soldiers rolling up their sleeve and donating warm whole blood, like we heard about yesterday, type O, and those patients were not getting, those recipients were not getting hemolytic transfusion reactions. So there was already a military precedent for this. But we tested this in a group of civilian centers, 1,500 patients. 120, this is 1,500 massive transfusions. 120 of those 1,500 technically received an incompatible transfusion because of the bunch of the trauma centers represented here were using type A and giving it to patients of unknown blood type, right? We would have used AB historically, but we were now using A. Some centers were basically going on the notion that there's only a 15% chance that they have B antigens on their reds, and if they do, well, they're probably not going to have an antibody reaction. Fingers crossed. So 120 patients in this series were patients who had AB or B blood types, and they got A plasma. So what happened to them? There was no increase in mortality as a result of the type A, technically incompatible transfusion. Type A plasma being given to AB and B type patients. There was no renal failure, no other complications. The things that predict mortality are the things that you would predict mortality. More red cells given more entry severity score and older age. So this is another study that was published just about the same time. 350 patients who were B or AB and got type A plasma. No difference in mortality, no change in early mortality, and no change in hospital length of stay. So this suggests that you don't have to just use AB as your plasma for your trauma resuscitations. You can use A. Gives you a much bigger pool. You'll be much more a friend of your local blood center that makes this available to you. And maybe you won't have shortages because we were having the odd shortage. We would use our AB that was thawed very, very quickly, and we were in a situation where now we were having to thaw AB plasma, and there was a delay. So now we keep a little bit of AB, but we keep quite a bit of A available. And it makes those cases where there's no plasma available because of thaw time much less frequent. So the third thing you need to do is make sure the plasma gets to the patient in a timely way, and there are lots of ways to do this. You just need to make that transport time shorter. So you can put it in your ED. So that can be done by putting a satellite blood bank in your ED or near your ED, and that's very effective, but it's very expensive. You can get a fridge. It doesn't have to be a massive thing like this, but there are refrigerators that you can use to put plasma in them in your ED so that you can give your plasma right away. Most places will use a runner, So it's not really a complicated solution here. It's really a low-tech solution. But the mechanics of how that's going to happen is going to be different at every place. So we don't have a blood bank runner at our place, I'll tell you. That means somebody from the ED has got to go. That means somebody in the ED who sees the patient needs plasma has got to direct somebody to go. And although the inclination in most hospitals, when there's some need for something to happen, is to levy that upon the nurse and say, okay, we're going to have the nurse do that. That's the usual solution to most problems in hospitals, right? I said, no, we're not doing that. Look, there's a trauma surgeon standing there, and they, better than anybody else in the room, is making a decision that the patient's in shock and is about to take some action on it. They are going to be responsible for saying, you go. So that's how it works. I hold my chiefs and my fellows and my partners responsible for saying, you go for the cooler. So that's how we do it at our place. But every place has a way to do it. You could tube this, but you're generally not going to be able to keep up with the volume of plasma and reds and platelets that you need. You could put thawed plasma in the field, and you heard a little bit about that yesterday in the discussion about resuscitation and fluids. So you can tube blood. I would say this is not completely proven. How many people tube blood? We tube blood at our place. You guys tube blood around? This is not completely proven. You don't know exactly what happens to red cells and platelets. It's unlikely to hurt the plasma, but when you put cells inside that little bullet right there and zip them across the hospital, there could be some hemolysis associated with that. I think for those of us in trauma, I mean, you hang this stuff as quickly as you can get your hands on it. The tube is generally not going to be a good option, but it's out there. Most places use a cooler. This is from the proper trial. This is a follow-up paper to the original proper data where they just wrote a paper to describe how patients were getting plasma to the ED, which I think is helpful because all of us are always kind of fretting about how we're going to get the plasma there. 11 centers participated in this study. One had an ED fridge. One had a cooler that was in the ED all the time, full of it. One had a blood bank in the ED. That's beautiful, but most places just used a runner. And this is the mean time to call, 9 minutes from arrival to, hey, we need a massive transfusion. And then after that, about 8 minutes to get it to the bedside. These are some numbers that you should know. We look at these at Trauma QA every month, or every quarter at least. The blood bank comes to trauma operations. You heard about Trauma Operations Committee. The blood bank comes and they have a dashboard for the MTP. They have wastage. They have time to prep the cooler, and it's beautiful. When the MTP doesn't work, generally the finger gets pointed at the blood bank first. They didn't have it available. We called them and there was a delay and blah, blah, blah. You sit down with the blood bank and they show the data. It's less than 3 minutes from call till first cooler ready. And then you take those data to the anesthetist, usually or the OR, who's saying, there was no blood. I called for blood. There was no blood. The blood bank had it sitting in the window ready within 3 minutes. They're generally not the holdup. Having this dashboard allows them to say, with all due respect, in this case, I don't think we were the holdup. Here's the data. That's helpful. You heard yesterday a little bit about field plasma trials. These two trials have both been reported in the last few months. They both came out in the same month in two leading journals, one in Lancet, one in the New England Journal of Medicine. So the top one was the PAMPER trial. The lead investigator was at Pittsburgh, but this is a multi-institutional study using field plasma. Some of you in here may have participated in this study. And the bottom one was a single center study in Denver run by the Denver Health Group under this person, Gene Moore. This is what the PAMPER data looked like. 500 patients, 230 of them got plasma in the field in the helicopter, 270 got just standard treatment in the field, which was red cells alone or just crystalloid. The median transport time, importantly, in the study was about 40 minutes. And you can see the difference in mortality. This is mortality as shown on this figure. Plasma, greater survival. It's survival, not mortality. But you see the patients who received plasma in the field were more likely to survive than those who received standard care, just crystalloid or just reds in the field. So this suggests a mortality benefit by putting plasma out there in your helicopters. Or I would argue putting plasma out there in smaller level hospitals if available. The point is the earlier you start the plasma, the better. But at the same time, the Denver group published their data in Lancet, and these are their data. Smaller study, 125 patients, 65 got plasma, 60 got standard treatment. Their transport time much shorter, so 16 to 19 minutes. And I would argue that if there's one dramatic difference that explains why the mortality benefit in the first one and not in the second one, it would be transport time. So for me in a rural state, that's really relevant to me. It suggests that helicopters carrying plasma is probably going to be a bit beneficial in my area. If you're getting mainly in town, close, bang, bang, shoot 'em up kind of trauma, then it may not be as beneficial for you to worry about putting this out on the trucks in the field. But I think the most important thing that you need to be thinking about today as you walk out of here and go back to your trauma centers is whole blood. This whole talk has been about plasma, but since I made plans to come and talk about plasma, and today, whole blood has become all the rage. It's not to say everybody's doing it, but everybody's talking about it. And I think this is the one thing that you should probably think about going out of here and focusing efforts on. Early plasma too, but you see Don Jenkins here and Brian Eastridge, who you heard from yesterday, talking about the science behind whole blood transfusion. This is your plasma, basically, right? It's plasma and platelets and the reds all in one. I think if you're in your trauma room tomorrow and you're resuscitating a patient who's actively bleeding and the MTP cooler is there and somebody holds up a red bag and and a yellow bag and they say, which one do you want first? I think the answer is the yellow one, right? We know patients tolerate anemia for a long time, but bleeding is the enemy. So I would give the plasma first if it's one or the other. And that's important for you to teach all your staff and remind your anesthetists, you got to give the plasma early. But whole blood is the perfect resuscitation fluid. Here's a paper that just came out that talks about how to do it. I love these papers. How do I implement a whole blood program? Here it is. This paper goes through all the steps for you. Regulatory issues, immune issues, transfusion compatibility issues, clinical considerations, how to work with your donor center, all that's covered in this paper. So what's the future? There's not a great method for rapid thawing of plasma, but if we had one of those that was commercially available, that would be good. Whole blood's here now, so the future is now in the whole blood. There's another paper here published in Shock just a few years ago on the use of this in Norway, so the Europeans are ahead of us. Dried plasma being used in Europe. This is coming to the United States. It has to go through the stages of FDA review and some clinical trial here in the United States. We've faced this question in our trauma QA, those odd scenarios where the blood bank can't provide the plasma fast enough. You get two really high acuity resuscitations, those 40, 50 unit ones simultaneously. You can get to the point where your blood bank either doesn't have enough staff to thaw fast enough or just exhausts their plasma supply. So in that case, should you use PCCs as an alternative? Well, that's a good question. There's not great evidence to support that, but there is some evidence to support that. It is expensive, but I would say the adage that would apply here is there's no cure for dead. Expensive is acceptable in cases where the alternative is death. So I would say if you exhaust your plasma supply and you have PCCs, I would go for it. And fibrinogen concentrate, another resuscitation in a syringe, if you want to think about it like that. So small volume resuscitation in a syringe, fibrinogen concentrate, super expensive, also mostly unproven. But those are options for you, and we've considered those in cases of plasma unavailability. So how you should make plasma available in your center, pack it right, that's 1 to 1 to 1. You should keep it thawed, at least some, and you decide what the right amount of thaw it is for you. Move it close to the patient somehow, or construct a system for getting it to the patient quickly, and activate early. Most important thing you can do in terms of your team's attention to the issue of active bleeding is activate early. Plasma in the community, plasma in the field, that's definitely here. The PAMPER trial supports that. PCCs or fibrinogen concentrate if you run out of plasma. I think that's an option for you for sure. Whole blood is something everybody should go home and think about. There are about 35 centers. Is Brian in here this morning? About 35 centers in the nation I know currently working on or have implemented whole blood programs, so it's coming. Thanks very much again for the invitation.